Okay.
They don't feed you guys? There's no lunch? What? I thought like everything like on this noon have it together by lunch. Alright. Alright, hey guys. So I'm Dr. Tang, one of the ICU doctors. I thought we'd talk a little bit about sepsis, which is one of the ICU things that we do, I guess. So there's a recently, does anyone know the definition of sepsis? So it used to, right, so it's kind of like transitioning. It used to be kind of SIRS with infection. And what's SIRS? Yeah. So blood pressure, tachycardia, respiratory rate, you know. So, you know, the issue was if someone came in with a UTI, right, and was a little tachycardic and was, you know, breathing a little fast, that would be sepsis, right? You'd probably send that patient home, right? But it just didn't seem right, the fact that, like, you call that person septic. Like, someone's septic, they're, like, sick, right? So, like, oh, we sent a patient home with a UTI and he was septic. So, actually, they actually changed it more recently to kind of like a more kind of in concert with what we think. When someone hears sepsis, it's not the kind of SIRS anymore. So kind of sepsis has to have one sign of kind of organ dysfunction. So it's kind of SIRS plus infection plus one organ dysfunction is sepsis. And then septic shock is SIRS plus infection plus one organ dysfunction plus the need for vasopressors, right? And so the definition of kind of organ dysfunction, what are organs that fail in sepsis? Kidney, so acute renal failure, ATM, liver, shock liver. What's that? Heart. Yeah, usually, I mean, you can get like, but usually like a really kind of mild, a suppressed myocardium is usually, there's other organs that are failing before that. You know what I'm saying? It's usually kind of a later one. Brain delirium. I'm a pulmonologist, come on. Right, acute lung injury, ARDS, and then DIC, right? So those are the kind of, so they go by the SOFA score. So anything greater than 2 would be considered, like, so respiratory rate, coagulation, liver, cardiovascular, CNS. And so if any of those signs with infection, with SIRS would be considered sepsis. So basically, you know, sepsis is a pretty, everyone has all their, you know, everyone kind of dies of infection after a while. Like, so 1 in 3 die of sepsis. Like, clearly, you know, patients with cancer and all this other stuff, end-stage renal, they're predisposed to develop infection, but it's usually the last thing that we see. So 1 in 3 patients in the hospital die of sepsis. And so they did a couple of studies. There's this article in Chest. They studied from 2004 to 2014, and they went by a clinical criteria and then also claims data, just trying to figure out what the incidence of sepsis was. So I think in their case, in this one they did, no, I didn't put that one out. So they did a clinical, this one I think did, like, if a patient had 4 days of antibiotics, was on a vasopressor, that met their kind of clinical criteria for sepsis. So that was their kind of clinical surveillance definition. And as you can see here, there was an increase in the incidence of sepsis based upon the clinical surveillance. And then they also did one with the ICD-9 code. And I think this is probably more of a sign of, you know, the coders in the hospital getting around and being more efficient. So there's a much steeper increase in the incidence of that for sepsis. But it looks like, you know, based on claims data and clinical surveillance have both kind of increased in sepsis over the past few years. And then this was the mortality, and both based upon the claim surveillance and by this clinical surveillance, they both kind of are improving a little bit. I don't think you can see this very well, but this is kind of a similar thing. JAMA kind of looked at it, and they used vasopressors, positive culture, and antibiotic usage. Pretty similar. Their incident was relatively flat compared to the Chest article, So it's, people try to think of ways of trying to figure out if there's sepsis or not, for instance, and this is just ways that they thought of. So it's either increasing or it's flat. So mortality seems to be getting better for most studies. All right, so someone comes in hypotensive. What's the first thing that you do? You can just say it. You'd be right or wrong. I'm not going to kill you.
Sorry.
Someone's hypotensive. Fluid resuscitation's one. Antibiotics is another. Finding the source is another. What's that? Yeah, so I think those first three for sepsis, right? So finding the source, fluids, antibiotics. The first thing that I always say is make sure it's sepsis, all right? Like I can't tell you how many times patients are getting like antibiotics, blah, 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 and I'm like, did we get a central venous sat? Did we get an echo? Did we do anything? Blow an RV, LBs, dysfunction, stuff like that. So always feel comfortable that you know what your shock state is first before you decide if it's sepsis. Now, I wrote this, I think, for the ER residents. So their first thing is to put the admission over it. Sorry. All right. So what's the definition of shock?
Inability for suicide organ.
Right. So the inability for the cardiovascular system to provide, oxygenation to the tissues, right? So that there's tissue hypoxia, that they're not getting adequate oxygenation, right? And so and then we always say, blood pressure is not a great measure for it, but we always look at blood pressure, right? So we can kind of use that as a framework of finding out what the problems are. So how do we kind of define blood pressure? What's the kind of components that go into blood pressure? Right, so it's cardiac output times SVR plus CVP, right? So your MAP is equal to your cardiac output times your SVR plus your CVP. And then what's your cardiac output equal to? Heart rate times stroke volume. And then your stroke volume is based upon, right, so your preload, right? So what your left ventricular end diastolic volume is going to be, and then what your contractility is, right? So if someone is hypotensive, it's one of these things that's causing the problem. They're either bradycardic, they're either preload is down, their contractility is down, or their SVR is down, right? So what are the different types of shock that we have? Cardiogenic, distributive, hypovolemic. It's a type of distributive. What's that? Obstructive, right? So what's obstructive shock? Tamponade or large PE, right? So it's basically preload. You can't fill your preload. You can't fill your LV. So so that was just kind of a quick review. We're not talking about the other ones. And then, so how do we determine, what are certain ways that we can determine how we can differentiate these different shock states? So central venous sat, right? We usually won't have a mixed venous, but we can have a central venous sat. And how good is a central venous sat? Like our central venous sat is a kind of a marker for your mixed venous sat, right? And your mixed venous sat is what happens in sepsis with a mixed venous sat. It goes up. And why does it go up? What's that? So if there's increased oxygen demand, you actually would take, right? So the mixed venous sat is actually the saturation that comes back to the RV, right? So if there's increased oxygen uptake, it would actually be decreased, right? But the reason why it's elevated in the sepsis is thought that there's mitochondrial dysfunction. So oxygen actually gets to the tissues, but because the mitochondria is dysfunctional, it's not actually uptaking oxygen. So basically, oxygen gets to the tissues, it's not being offloaded, and it comes back, right? So what happens in cardiogenic shock? Yeah, but what happens in the mixed venous? Is decreased, right? So the way I kind of think about it, about shock states, is like It's really stupid, right? So don't laugh at me, but I'm just saying. So pretend like you have workers here at this station, and there's trains going to where they need to work, right? So let's say that you have, let's say that it's really slow, that it's just not getting the workers out in time, right? So let's say that let's say that the trains take an hour to get there when it's supposed to be half an hour. So you have the workers here. It takes an hour to get to the tissues. They're waiting for it. So this is cardiogenic shock, right? So once the workers get there, they're like, okay, everyone out. You guys are late. We need all the workers off. And then it goes back. So the workers that are coming back on the train, there are not that many left, right? In hypovolemic shock, there's not many trains going. So because there's not as many trains going, everyone's coming off too as well, right? And then in sepsis, there's enough trains, it's moving fast enough, but they're not able to get off the trains, so they return back with a lot of workers. So that's my little, how I kind of think about it. So central venous sat is a way that we can kind of differentiate. The problem with central, like you can't, the central venous sat in my mind is something to just do a quick saying, like, okay, it's not horrible cardiogenic shock, or like it kind of thinks of sepsis. There's many things that can affect it, right? Like you would never use a central venous sat by itself as a data point to make major decisions, right? Like basically, like if it's low, you'd say, okay, well, let's get a stat echo, right? But nothing that would actually change management and be like, oh, well, it's a low central venous sat, let's stop antibiotics, right? Because the thing is, like, if you think about it, the patient's hypoxic in ARDS and in sepsis, and the arterial sat is 90% or 88%, right? The venous sat is going to be low because basically there's not as much oxygen getting there, right? So you get back and you're like, oh, well, this mixed venous, your central venous sat was 55, it must be cardiogenic shock. Well, no, like if the patient's markedly anemic, more is going to come out. If the patient is hypoxic on the arterial side, it's going to be low. So you know what I'm saying? Like, so you need to kind of make sure when you take a look at the central venous sat, it's more just to be like, okay, you know what? It's 79. We feel comfortable with sepsis. We can get the echo, but it's not emergent, right? But if it comes back at 60, well, let's get a stat echo and make sure that that's the case. So it's a really quick way of making sure that you're not missing something. All right, so so the next one too is what you can look for is, yeah. I mean, we don't do that now in medicine, do we? No, right, clearly, right? So if you have a patient who seems to be markedly vasoconstricted in the kind of model, you think, okay, well, for some reason cardiac output is not the problem, you can kind of get a better idea of what it is. Clearly in the sepsis phase, you can get both where you actually have myocardial suppression too as well. The next thing that I thought I would talk about would be like procalcitonin. So procalcitonin, which you guys can't order on the floors for some reason because, well, I'll get to the study of why. So basically, it gets released by the thyroid C cells, right? And most of the times it gets really just, procalcitonin is not in the system because it gets broken down to calcitonin in terms of calcium mag kind of homeostasis. But in terms of when there's inflammation or LPS, so LPS is basically on gram-negative rods, right? So it's a TLR4 agonist. So that's a direct pathway, and then an indirect pathway with all these kind of inflammatory cytokines causes release of procalcitonin. So the data has been pretty good. This is the first study that kind of came out. They said that the sensitivity was actually like, they said in this study was high, like 88%. So this is Mueller's study, and they were able to show that they had 89% sensitivity and 94% sensitivity, which was like pretty amazing. And you can actually kind of follow procalcitonin levels to try to see if antibiotics are adequately treating it. Like it gives you kind of we don't do it here in this hospital, but there are some studies that suggest that you can follow that as a means of saying like the patient's improving or not. Usually it's not rocket science, right? If someone's getting better, they're getting better. You don't need to confirm it with a procalcitonin, right? Like if a patient's becoming less hypotensive, organs are getting better, the procalcitonin is going higher, I don't think we would say you would switch to antibiotics. So these numbers were pretty good, 89 and 95, right? So, yeah, I don't know why I looked it up. It's right here. And the other ones really weren't as good, as you can see. They looked at IL-6, ERP, lactate, sensitivity, and specificity was much lower than procalcitonin. So they did it in Lancet Infectious Disease. They took a look at 30 studies and basically just did kind of a meta-analysis of all of them. And the sensitivity was about 77, and the specificity was about 77. So still decent, but not as good as that initial study. And this is an area under the curve. I don't really know what it means, but I thought I'd put it in. All right, so I don't know why there's that line there. So this is too small for you to see, but you'll probably see this in the New England Journal. About a year ago, they came out and said, is procalcitonin, should we be doing it or not? So they basically did a study. The medical centers that did procalcitonin, no one actually followed it, right? They would draw the procalcitonin, it was low, and no one would stop antibiotics, right? So people are like, it's a waste. It's basically wasting money, right? So which it kind of makes sense, right? So the fact that procalcitonin is a test. If your pretest probability is so high, don't send a procalcitonin, right? Like if you're saying like this patient is an oncology patient, febrile, hypotensive, this is definitely sepsis, then don't send procalcitonin because it comes back low. It doesn't change your management, right? It's really on those patients that I'm not sure where the shock state is that you want to kind of send it. And that when you send it, you have to have the conviction to say, okay, you know what? If this is low, I'm going to stop antibiotics, right? I have a low clinical suspicion that if it's low, I'm going to just stop. So if someone comes in hypotensive, not febrile, no clear source, you kind of send it the first day, send it the second day because it increases over 24 hours. And if they're both negative, you should stop it. Right. So basically the New England Journal just said that we weren't using it correctly. So basically they took it away. And then we started doing it too here. Like we rolled it out and then basically we're kind of doing the same thing. So now only the ICU can use it, which kind of doesn't make sense. Because like from a pulmonologist, right, there's a lot of times where I'll see on a CAT scan, there's an infiltrate. I need to know is it inflammatory versus pneumonia, and it's helpful for me, So, but hopefully as we use it more consciously, we'll be able to expand it again. All right. Oh, so I think the kind of gold standard of trying to figure out shock states is kind of evolving. So basically, bedside ultrasound has kind of like taken over everything, right? It's just, you can get a bedside ultrasound. You can take a look at the RV. You can take a look at the LV. You can take a look at tamponade. You can take a look at the IBC to figure out if there's kind of volume responsiveness or not. They did a study. So basically that, there was before the ultrasound, they had physicians look at the vignette and say, based upon this, what do you think the hypotension was secondary to? And then after the ultrasound, if they felt comfortable, they made a diagnosis with that. And as you can see, there's significant change versus how many people were septic, cardiogenic, obstructive, and hypovolemic. What kind of doesn't make sense to me in this study is that they were all hypotensive, but every single diagnosis went down. You know what I'm saying? Like, there had to be a reason for the hypotension, but like based upon this, the pretest probability was 0.4. They thought it, but now it's 0.3. So I don't know if the patient wasn't septic, what most of those patients became. Like you would think that it would be even, like, you know what I'm saying? So, but I guess they just said that, I guess the reduction just meant that the initial diagnosis was incorrect. I don't think they went over and told you exactly what the breakdown of, if a patient wasn't septic, it turned out to be PE or, but so there's, significant findings on the ultrasound that really can help us determine what the true state of shock is. That's too small, and this wasn't a really good slide anyway. All right, so the results of that study actually showed that there were 13 cases that even at the end, they couldn't really figure out what the hypotension was. And so without those cases, the ultrasound was about 97% predicted exactly what the final shock state was determined. So it's been it's really kind of revolutionized what we do. All right, so now that we know it's sepsis, all right, so now what? All right, so we said kind of confirm the source, right? So this is a study, I think this was a biliary source. Oh no, so this was, so this was a surgical, I think this was a perforation. And so I don't know if this is really confirmed the source. This is kind of like source control more than confirm the source. This was patients that came with a bowel perforation. And basically they said that every hour that the patient wasn't in the OR, they died, right? So like, you can have a patient here, perforated bowel. It doesn't matter what you do with fluids. It doesn't matter what you do with antibiotics. If you don't take them to the OR within 6 hours, the patient's dead. So this is like one of those things that you fight. This is like one of the fights that you don't lose with surgery, right? It's kind of like, oh, well, you know what? Why don't you try and stabilize him a little more? He's too unstable to go to surgery. It's like he's unstable because his bowel perfed. You know what I mean? Like, there's either go and speak with the family and say, we can't do this. We have to make him comfortable. But don't play around with this game. Like, if there is no like optimization of like shit in your perineum, right? Like, okay, I can't really optimize that. He's got take that shit, basically take that shit out, right? So basically, as you can see here, is it larger here? Oh, it's actually larger here. Yeah. So 60-day survival was 98% when they took me to the OR within 2 hours, right? And then by 6 hours, everyone was dead, right? So if you ever run into problems, just think like, look, we got only like within 2 hours, it went from 98 down to 78. So like clearly fluids, antibiotics, but the first thing really is kind of source control. And this is another one. This was cholangitis, decompression. And you can see here, within 12 hours, mortality is significantly better with decompression after 12 hours. And so they both did source control. So this was decompression. And then also delay and effective antibiotics too. So both things, right? So it's not one or the other, right? So it's kind of like source control and antibiotics. So timing of antibiotics. And so this is a little weird, right? I mean, I guess this is all based upon randomization, so you have kind of equal patient populations. But like they clearly show that, within 0 to 1 hours, the mortality is 24.6 hours, and then greater than 6 hours is 33 is the mortality. But like, how many times do we hear like, oh, grandma was like febrile for the past 3 days, and then we brought her in and she wasn't looking well, right? But then the only thing that matters is right when they hit the ER. You know what I'm saying? Like, so I don't really know how well they kind of trust this, because like, I guess you would think that within the randomizations, every single group had grandmas that waited X amount of time. But you know what I mean? Because it's not like once you have a fever, you're like in the ER. Like there's like multiple factors prior to it. But somehow this study showed that, no, the only important thing is right when you hit the ER is that first hour. So there's no reason to argue with it, though. I'm just saying it just seems weird, that variable. But clearly, I think antibiotics sooner, like it's hard to argue that antibiotics later is better. I'm just saying the study seems a little weird. But yeah, clearly we want to get antibiotics in as soon as possible. I didn't go through every single slide, so I'm not really sure what this is. I think this is mortality. Yeah, this is just another way of showing mortality. And this is just, basically kind of like it's important every single, if it's septic shock, severe sepsis, and even sepsis. Okay, yeah, some more stuff, some of the same thing. Okay, so, all right, so volume resuscitation, right? So we now know with the kind of Manny River study and all this, we think that like patients who come in, they're markedly venodilated, right? So they need actually volume resuscitation. They act hypovolemic. So what's the best fluid to give? Like we give saline, right? We give saline, more saline. Right, so LR is probably better. And, I think in medicine, oftentimes we get like this, like you hear one thing and you're like, okay, well, I never can give that, right? Like we hear lactated ringers, then we're like, oh, is the patient making urine? Because if they're not making urine, then they become hyperkalemic, which I've never seen, right? So, but like a lot of people always have like things about not giving lactated ringers because like if they're not making urine, they're worried about hyperkalemia, which in actuality, the concentration of potassium is less than what your body serum is. So it really shouldn't cause much in terms of problem. So I think lactated ringers is probably better. This study actually looked at balanced crystalloid, which was lactated ringers and plasmolate. So there wasn't really much difference in here that they actually gave the same amount. Basically, everything was kind of equal. There really wasn't. So this was a meta-analysis, and basically they kind of showed that there seemed to be an improvement with balanced crystalloid over saline. There wasn't much in terms of mortality benefit, but definitely kind of renal replacement. That was what was kind of beneficial. So I think that we really should be thinking more about using lactated ringers, because what happens with normal saline? What's like the one thing that always happens? Right. They get this non-gap acidosis, and then when you're pushing bicarbonate later, right? Like, and basically with the acidosis, you cause like your basal pressures not to work very well, and based upon this, it's also kind of renal dysfunction. So I'm guilty of it too, right? So I'm sitting here and I'm saying yes, but I think I'm more and more like just saying lactated ringers should be really the kind of volume resuscitation. What about albumin? So it's about the same. There's really no improvement with albumin. So they did 4% albumin compared to normal saline, and there was no difference in mortality. Like none of the endpoints were, beneficial. So even though you would think that maybe having more colloid would be easier and kind of like it'd be more intravascular resuscitation, it really hasn't been shown kind of like in studies. Yeah, so here, primary outcome, the p-values are like 0.9 and 0.99, so there really is like very little difference between the two groups. All right, so so the kind of revolutionary thing, so when I was first training, like the medicine people, like we were like wusses, right? Like we were like, oh, the patient has a history of like end-stage renal, or they have a little bit of CHF, and so they would get like 500 cc's of fluid, and then we would just start pressors, right? So if you kind of think about it, like the whole point about shock is to try and perfuse your organs, right? So if you have no preload, right? If I just increase SVR, am I going to improve tissue delivery of oxygen, right? So basically, Manny Rivers, he's a guy, an ER guy, I think Henry Ford. He has his own little ICU in the ER. And basically, he thought that, based upon goal-directed therapy, you would put in a central line, and you would volume resuscitate to CVP between 8 to 12. And then if the MAP was still low, you would start using pressors. And then you measure central venous sat. And if that was low, if the patient was anemic, less than hematocrit less than 30, you would get transfused. And then if there's still central venous sat was low, you would add dobutamine or milrinone, right? And so more people, so there was a mortality benefit in doing this early goal-directed therapy. The main difference was really kind of volume resuscitation. So in the early volume resuscitation. So in the treatment arm, they got significantly more fluids than the control arm. So it's unclear if the transfusion or the Primacore was really beneficial, because not a lot of patients required that. And, they didn't do a subgroup analysis of those patients that they were either in this protocol or not in the protocol. So no one got volume resuscitation, vasoactive, and then let's break it off and figure out if blood transfusion was better and Primacore. And then they didn't break it off and say Primacore is better. You understand what I'm saying? Like they were either all in this protocol or just kind of usual standard of care. So I don't think a lot of people believe the transfusion or the Primacore. But what this allowed us to do, even though we know that CVP is a horrific measure of volume status, it basically allowed the medicine doctors not to think and overcome their fears and just say, hey, we can just give volume now. So now, if you think that the patient is dry, it doesn't matter what their EF is, you just give volume because you can feel comfortable. You should have a way of measuring volume status. They use CVP, which is horrible. We use IVC. Right? So feel comfortable, like volume, this just allowed us to feel more comfortable with volume resuscitating patients. So p-value was 0.009 in terms of mortality with early goal-directed therapy. Kind of septic shock 0.04. All case mortality was significantly better. So a lot of this is not the way that we practice anymore, but it really changed our mindset about volume resuscitation versus pressors. So there's been kind of other studies that have kind of shown that this kind of early goal-directed therapy is probably not so basically what early goal-directed therapy means is the fact that you're just going based upon the numbers, right? Like you have to target the CVP, you need to target this MAP, you need to target this central venous sac. So when they said, so basically Manny Rivers' study basically changed the whole landscape. So everyone's getting fluids now. So now when they do the studies, they don't see a difference between when you need direct numbers versus like standard of care, right? Because standard of care has changed because now we're much more aggressive with fluids. So so this is just to know, like when you see like the Arias trial or the PRISM trial, we'll be like, well, early goal-directed therapy doesn't work anymore. And it doesn't, right? So the whole point about the Manny Rivers trial is to change our mindset that volume resuscitation, then pressors, and antibiotics. So it's not that we don't give volume anymore. It's the fact that the standard of care arm was giving just as much fluid as the early goal-directed therapy arm. They just did it a different way. So I don't know if you guys know, like there's a surviving sepsis thing in the ER. So basically, when someone comes in, they need to draw blood cultures, they need to get a lactate, they need to get a lactate within 4 hours again. They need to give 30 cc's per kg of fluids to everybody. You need to check for like skin tone or something like that, like in terms of volume resuscitation. They need a volume status. And so basically there's like a 3-hour bundle and a 6-hour bundle. And the studies would suggest that if you get this done in 3 hours, mortality is better. Clearly there's certain things about it that it really should be the framework for everybody. There are certain people who come in volume overloaded septic already that you really shouldn't be giving 30 cc's per kg, but like we just document this to say we did a volume assessment and we don't feel like this patient requires volume. But it's more of a guideline for almost everybody. It does show that if you get these certain things done, and there's been an argument that if you can get this done within an hour, that mortality is even better, right? So I think that over time, we're going to start thinking about sepsis as almost like a STEMI versus a stroke. That really, if we get it done in that first hour, you're going to see a lot of improvement. It's just the fact that there's no kind of like definitive change about our treatment for sepsis. That like there isn't this mindset yet of like someone coming in with sepsis is just it's probably good, it has a worse outcome than someone who's coming in with a STEMI. But we don't mobilize everybody for sepsis like we do for STEMI. But I think somewhere down the line we probably will. All right, so which vasopressor should we use? Let's say like we volume resuscitated, we feel comfortable that they're volume resuscitated. So what are the studies in terms of vasopressor? What's the first one we should use? What's that?
Norepinephrine. Yeah,
so Levophed, right? So let's take Levophed. In a study with vasopressin, right? So is it better? So the patients we often use vasopressin to kind of reduce the amount that we need for Levophed. So is vasopressin been helpful in terms of mortality or not? So it's interesting, right? So the thought would be that vasopressin by itself, adding to just increasing dose of Levophed, overall there's not a change in mortality, right? But they did a subgroup analysis because the thought was the fact that if you needed high dose Levophed, right, and you need added vasopressin, that they would do better, right? But the study, because that was a pre-planned subgroup analysis for the study, it was actually the opposite. So patients who needed low levels of Levophed, when they were added, vasopressin was added to it, their mortality was better. So it's a little hard to know when you're going to use it because you're like, well, I don't know if it's low dose Levophed or not. But I think that when you're getting to like maybe 20 mics of Levophed, you should probably just add vasopressin because there is mortality benefit. And it wasn't one of these things that they took a look at the study and then went back and dissected and like, oh, well, look at this variable. This was a pre-planned subgroup that they were planning on looking at. So I think that early vasopressin probably makes sense because if you kind of think about it, like what are the different vasopressors are what? We have Levophed. We have dopamine, which we'll get into. We shouldn't really be using dopamine. So phenylephrine and epi, right? So what does Levophed hit? What does norepinephrine hit? So what is it? Levophed is alpha and a little bit of beta. Neo is pure alpha. Epi is everything, right? So if you kind of think about it, like we were like, okay, well, Levophed not working. We're hitting alpha and beta, right? So let's add Neo, right? But it's just hitting more alpha, right? It's not really. I don't really think that there's any difference of like adding Neo. You could just go up on the Levophed. It's just the fact that we maxed out on Levophed. But if you're saying that there's still alpha receptors that are still going to be hit with Neo, probably could have done it with Levophed, right? So you're basically just hitting the same kind of receptors over and over again when you go from Levo to Neo to Epi, right? So vasopressin actually does something different. So that's kind of in my mind is the fact that if I feel like I'm already hitting alpha a lot, why don't I just actually try out another thing? It's kind of like, someone who's got high blood pressure, you do the beta blocker, you keep going up on the beta blocker. If it's not working, well, maybe you want to try a different strategy, right? So that's my thought. So I usually just use vasopressin a little earlier. Like I usually don't go from Levophed to Neo. I go from Levophed and vaso first. So dopamine and Levophed. So we use a lot of dopamine here peripherally, which is like my biggest pet peeve, right? Like, especially in kind of young, viable patients, like if a patient comes in hypotensive, the only reason to add dopamine, like in this hospital's crazy mind, is that, oh, we don't need to consult the ICU and bring them to the ICU. The patient's sick, right? The patient's initially sick. For you to play games about like not admitting the patient to the NICU is just ridiculous, right? Put the patient on the right, on the best medication, just so it's not like this little game. So like, oh, we can admit them to 4PW instead of the NICU, right? Like, because what always happens too is like they get to 4PW, they're on 5 mics of dopamine, and now they need to go to 7.5, and then you call the NICU and they're like, oh, it's just 2.5 more. Do you think you can get them off? Well, no, right? Like it's not me. Like I don't have control. The patient's freaking hypotensive, so I had to go up to 7.5, right? But in my mind, it's kind of like these things like DOPA on the floor. If you're going to use it, should be if like the patient's been stable 2 weeks in the ICU, you can't get them off. Patient's not crashing. Like, okay, maybe I switch them down to 5 mics of DOPA and get them to the floor because family's just crazy. I don't want to do it. But like in my mind, if you get like the MICU fellow or the attending, like I would just say, really? Like, no, Levophed is better than DOPA, right? And actually, right, so we can do peripheral DOPA. But what's worse if it extravasates, Levophed or dopamine? DOPA. DOPA's worse if it extravasates. We only did it before was because of renal perfusion. Like this is like an old dinosaur in the times of like, oh, someone's in acute renal failure, we're going to give a little DOPA for renal perfusion, right? Which we know that went off. But now this continues like, oh, well, we can give peripheral dopamine. So it's just, in my mind, it's one of my biggest peeves. So basically dopamine is not as effective as Levophed. It causes more tachycardia. It causes more arrhythmia than kind of Levophed. So, and when they did this study, this was actually in all shock states. So, right, so in cardiogenic shock, is dopamine better than Levophed? So that used to be the thing, right? Like, oh, if there's a little bit of cardiogenic, dopamine will have a little bit of kind of extra squeeze compared to Levophed, so it's better. They actually died more, right? So they did a subgroup analysis. In this case, again, pre-planned, in patients with cardiogenic shock. Patients on cardiogenic shock on dopamine died more than patients on Levophed. So like, there's really no reason for Levophed. Okay, and then so this is something that we don't have here, but there's actually a newer vasopressor. There's an angiotensin 2 receptor. So basically, it's an angiotensin 2. So basically, it improves blood pressure that way. It hasn't shown changes in. Sorry. Hello. Hey, I'm in a lecture. So basically, it was definitely shown to be better than placebo in terms of improving MAP and decreasing the usage of other vasopressors. Mortality. So MAP response definitely was, p-values less than 0.001. And you can see the SOFA score really didn't change that much. Levophed was down. It's interesting is here, all-cause mortality at day 28, p-value was 0.012, but there was actually a reduction. So it's like 75 compared to 85. So I don't know if the study was big enough to actually see a mortality difference. But, I've been trying to fight to get it. It's expensive, right? Like all these medications. But, it's like another thing to kind of add to our armamentarium. I guess you can make the argument that if someone's already maxed out on Levo, Neo, Epi, and vasopressin, like adding angiotensin 2, unless you have a clear mortality difference, it's just adding money, and clearly you should be having more goals of care discussions with patients' families. I think we should have it available. But I guess we probably would just abuse it like everything else. So this study in 2014, they looked at improving like MAPS of 65 compared to MAPS of 85, and there was no difference. So that's why we kind of still use 65. Yeah, so there was no difference between the two groups. This is I talked about this. This is the guidelines or sepsis. So kind of like other things about septic shock. So patients with steroids, has steroids been helpful in septic shock? So when I trained, steroids was going to like this. There's like this beautiful thing, right? So Anand came out with this thing about relative adrenal insufficiency. So basically, patients who responded to cosyntropin versus not, right? So he would take these patients, he would do cosyntropin. Patients who didn't respond to the cosyntropin with a bump in cortisol, their mortality was worse, right? So he did that first study. It was beautiful. And then the next study, the cosyntropin study, the patients who didn't respond so everyone got steroids, placebo versus steroids. And then he showed the patients who didn't respond, who got steroids, their mortality decreased. So in non-responders, so we were like, wow, this makes sense. Like this is like, bedside to like doing this, we can figure it out. It makes sense. It's all crap. So basically the Corticus study came out and responders, non-responders, nothing. There's no benefit in steroids. We still give it, right? So it does help with blood pressure, doesn't change with mortality. So there's a decrease in vasopressors. I always kind of think about it, if a patient has been on steroids recently, I'll usually give stress dose steroids. But really and then if someone's dying, we do stress dose. No one dies without steroids. So, but unfortunately, this kind of like really elegant description a few years ago kind of went by the wayside. More and more studies suggest that it's not good just for empiric steroids. So this is a Corticus film. So the funny thing too, right? So the guy Anand, initially the French government told him that because it was adrenal insufficiency, he had added Flugelcort, right? So Anand, when he first came out, he was like, I don't know why, it's just hydrocortisone. The French government made me do Flugelcort, but that's all crap. So then when the Corticus trial came out and hydrocortisone wasn't good, then he changed his tune and be like, no, but my study used Flugelcort. So now we really need Flugelcort. Academic people are fun. All right, and then so this is another one. So So basically, like when I was training, we had all these things that were helping sepsis, and then as we find out, like it really didn't work, right? So there was like a study in a SICU population for tight glycemic control between sugars between I think 90 to 150, and it showed that patients who had tight glycemic control actually did better, right? And then we've done more and more studies. This is a nice sugar trial. We showed that tight glycemic control actually didn't change mortality. There's actually more kind of like adverse effects on patients who had a tighter glycemic control. So basically what came out was we now keep sugars below 200. There actually hasn't been any studies to suggest that there's any mortality benefit with that. It just kind of changed our mindset to say, okay, well, there needs to be some type of glycemic control. There really is no data to suggest that. It seems crazy to be like, okay, well, let the sugars run as wild as you can. There really hasn't been a good study to suggest that any type of glycemic control is good. But the major issues with these tight glycemic controls was that they ran into hypoglycemia. So if you target 200, I don't think you have to worry about that. So I don't think you're going to run into problems with that. So basically, this is kind of like talking about patients in the general population and the patients who develop sepsis. So, you know, like we always have like these. Well, we don't always. Most of the times we don't. But like we should have to sometimes like good saves. You know, like oh, this patient was markedly septic, and you know we get them to 4PW, and then they go to rehab, and you're like, wow, that's great. But at the end, this is I think after 12 months, their kind of quality of life is significantly worse after septic shock. Like both on physical functioning. So this is, I think this outer ring, this like spider web, this outer ring is just the general population. And then this is, you know, after 30 days. And then actually 180 days afterwards. And you can see that even after 180 days, they don't get back to their normal physical functioning, physical problems, body pain, general health, vitality, social fun. Now these are all like kind of questionnaires that they did, right? So you can see that even you know, based on age match, they're clearly worse even a half a year later. So don't get septic. This is a slide I didn't review last night, but it looks like there's patients still after. I mean, and this isn't kind of rocket science, right? The patients who get sepsis here, most of them have kind of like are poor protoplasms to begin with, so their all-cause mortality and their cardiovascular events afterwards are going to be higher. But someone got this published. That's it. All right. Any questions? All right. So I have the articles. I'll print out a list of the articles that I went over, and I'll give them to you, Rachel, and then we'll just send those out. All right. But those are kind of like the major kind of sepsis things trying to think about, and like kind of like why do we do this? Why do we do that? You know, it's kind of guides this. All right. Thanks, guys.
Thank you. I literally just